We have a lecture now, IVAS versus FFR in assessment of deletion by Dr. Ajit Mullasari.
Thank you very much, Srinivas, and thank you very much, Marty, for inviting me here for this lecture, IVAS versus FFR for lesion assessment, what to choose and when. Why should we do it? And my agenda for this talk is 4. Why is it important to diagnose ischemia-producing lesion? FFR, what is the status for assessment of ischemia? There is an anatomical to a functional disconnect, and why is it essential to treat the lesion optimally? Why is ischemia all that important? That's the first question. And clearly, if you look at the SPECT imaging data, we clearly know that in the red is the abnormal annual risk of death or non-fatal MI in patients who have an abnormal SPECT thallium, and in the green is patients who have normal stress thallium. And clearly, there's an annual risk of death in MI is 10 times larger when signs of ischemia are present. So clearly, ischemia is important. The current serial nuclear imaging substudy data in 314 patients with coronary artery disease who were treated with either PCI plus optimal medical therapy versus optimal medical therapy and myocardial perfusion done prior and 6 months after treatment showed that in patients with angiographically proven CAD, the risk of events is proportional to the extent of ischemia. So more the ischemia, the more you get events. And if you treat them and look at them 6 months later and look at their risks, patients who have more than 5% reduction in ischemic myocardium are the people on the top, and people on the bottom who have lesser than 5% reduction of ischemia do worse. So clearly, you treat people with ischemia and they do better. So in conclusion, in patients with suspected CAD, the risk of death in MI is 10 times larger when ischemia is present. In patients with angiographically proven CAD, the risk of events is proportional to the extent of ischemia. In patients with proven CAD and ischemia, you treat the ischemia and you decrease death in MI hard endpoints. And in proven patients with CAD without ischemia, annual death of MI rate is 1% and not improved by PCI. So in conclusion, functional information is paramount for optimizing treatment of patients with CAD. In the United States in 1993, patients, only 30% had a treadmill test before undergoing an angioplasty. So 70% of patients did not have proven ischemia when they underwent a PCI. So why we need fractional reserve is because fractional flow reserve is the ratio of maximum myocardial blood flow in the presence of stenosis to normal maximal myocardial flow. I'm not going to look at all these complicated formulas, but at the end of the day, the bottom line is FFR is equal to the PD by PA. PD is the flow distally and PA is the flow proximally after maximal dilatation. The important thing with fractional flow reserve is that the pressure drop across the stenosis increases with flow in a nonlinear fashion, increases with lesion length, and increases with smaller luminal area. So the characteristics of FFR are: 1, it's a well-defined normal value of 1 irrespective of arteries, irrespective of patients. It's well-defined. The ischemia threshold is 0.8, takes into account collateral flow, accounts for the extent of effective perfusion territory, extremely reproducible, not influenced by hemodynamic changes like blood pressure, heart rate, or contractility, valid in almost all clinical cases and lesion subsets, and is unsurpassed in spatial resolution. So the important issue today to look at is intermediate lesions. Here is a gentleman, 75-year-old gentleman, undergoing a pre-surgical evaluation for a non-cardiac surgery. The lesion on an angiogram looks significant in the circumflex, but you look at the FFR, it's 0.82. You can safely send the patient for his surgery. The DIFFER study was a very interesting study. 325 patients who were scheduled for PCI without proof of ischemia were randomized to deferral of PCI and performance of PCI. If the FFR was more than 0.75 in 91 patients, they were deferred from PCI. If the FFR was less than 0.75 in the next group, they had PDCA and formed a part of the reference group. And the performance of PDCA group, there were 2 groups again, more than 0.75 and less than 0.75, and the left arm formed the reference group and the right arm formed the perform group. And what is interesting is that if you deferred PCI, the cardiac death and acute MI after 5 years, if your FFR was close more than 0.75, the event rates was only 3.3%. You performed PTCA and your event rates were 7.9. P-value is 0.2, but if you had a larger number, I'm sure that this would have been. And most importantly, in the reference group, the event rates were about 15.7. So clearly, by differing the PCI, you definitely did no harm to these patients and maybe some good in these patients. The second subset is angiographic multivessel disease. Here is very often a patient who lands upon your lab has an LAD, which is borderline, a ramus, which looks about 70%, a circumflex, which looks tight, and 2 lesions in the right. It's a 72-year-old gentleman, small non-ST elevation 3 weeks earlier. FFR there, 0.97, don't need to treat. Ramus, FFR, 0.90, don't need to treat. Circumflex, FFR, 0.48, need to treat. And RCA, 2 lesions, FFR, 0.85, don't need to treat. A multivessel disease becomes single vessel disease, and you fix it as a single vessel stent. If you look at stenosis classification by angiography, you find interestingly that lesions which are 50 to 70%, most often FFRs are less than 0.8 only in 35% of patients. Clearly, you're over-treating 65% of patients in this subset. If your lesion characteristics has 71 to 90%, your FFR less than 0.8 is 80%. So clearly, you're again over-treating 20% of patients, and 91 to 99, still there's a 4% patients whose FFR is more than 0.8. Again, 4% being over-treated. So clearly, you're over-treating patients based on the angiographic pictures. The most important trial for the FFR was the FAME, and this was basically in multivessel disease of more than 50% in 2 or 3 major epicardial vessels who were amenable for stenting, who were randomized, 1,000 patients, 500 approximately in each arm, angiographic guided PCI versus FFR guided PCI. FFR was measured in all indicated lesions, and the stents were placed in only those with FFRs less than 0.8. A 1, 2, and 5-year follow-up was done. This was published in the New England Journal of Medicine, and clearly what it showed that the stents per patients deployed in angiographic-guided PCI was higher. The contrast agents used were higher in volume in patients who were angio-guided. The equipment cost was higher in the angio-guided patients. And most importantly, the event rates, myocardial infarction, and composite endpoints were lower in the FFR-guided group. And most importantly, on a 720-day follow-up by Kaplan-Meier survival curve, the patients with FFR did better than angio-guided. So also, the symptom status did not change whether you did it FFR-guided or you did it angiographic-guided. So the conclusion there was FFR is not only good, but is maybe better than angio-guided PCI in multivessel disease in patients with more than 50% stenosis, clearly in that subset. Now, what is also important is if you defer those lesions, 513 deferred patients and 509 FFR-guided patients, follow them up at 2 years, the 31 myocardial infarctions which happened were 22 periprocedural. The 9 late myocardial infarctions were 8 either due to a new lesion or a stent-related lesion, and clearly only 1 myocardial infarction occurred to the originally deferred lesion. So only 1 in 513, or 0.2% of deferred lesions resulted in late myocardial infarction. What about revascularization? Similar. 53 repeat revascularizations at 2 years, and this was 37 in new lesions or in a restenotic one. 16 originally deferred lesions, 6 did not have FFR or unfortunately had a procedure despite an FFR of 0.8, and only 10 which had originally deferred lesions had a clear progression requiring repeat. So clearly what it says is the chance of myocardial infarction or repeat revascularization is extremely low if you guide your procedure FFR guided. Your FFR also improves your costs by about $2,400. If you can look at the top, the angiogram is $16,700 versus FFR of $14,300. So clearly, this is a very important thing to understand. Bifurcation lesions are another subset. You stent the LAD, and the diagonal looks pinched. Your luminaria on IVUS looks 2, MLD looks 1.2. Clinically, you would feel maybe we should stent this or balloon this or provisionally treat it. You look at the FFR, 0.85. You do not need to treat it based on the data which is published in the JACC in 2005, that in patients with lesions with more than 75% stenosis, only 20 lesions, that is 30%, had functionally significant lesions by stenosis. So even if you have 75% stenosis on angiogram, less than 30% needed treatment because the FFRs were low. And in relatively large branches, that number came up to about 40% because the flow was high. Remember, in serial stenosis, you need to fix the distal lesion before you look at the FFR of the proximal, because that may affect it. Here is an angiogram. The red marker clearly shows where the distal lesion is, and the white marker where the proximal lesion is. The distal lesion FFR is 0.63, you fix it, and then you look at it, and clearly the FFR is 0.81 to 0.86. Do not need to treat the proximal lesion. Another subset where FFR is very good is left main disease. Clearly look at the angiogram. The red marker shows a significant lesion, maybe 60 to 70% in the ostium of the left main, 47-year-old gentleman, stable angina. You do an IVUS, MLA is 4.4. You look at the FFR 0.86. You don't need to treat such patients. But other way around, you have a 50-year-old gentleman, stable angina, ostial left main, 20% stenosis on angiogram, MLA on the IVUS is 6.1. You may say, maybe not treat, but put an FFR in this patient, which is the lower column, and clearly the FFR says 0.7. You need to treat. And the difference is that the gentleman on the right side with 50-year-old has a large blood flow area of supply, while the left gentleman, the LAD, may be a type 1 LAD with less flow. So clearly, it's important to use FFR to make a definition. How good are interventional cardiologists in eyeballing? 50% inter-observer concordance in left main stenosis. So clearly, we're not very good at two people saying the same thing in left main stenosis. 23% of patients with left main disease get overtreated, and 7% get undertreated in an intermediate left main stenosis. And what is more important, that if you treat that left main stenosis or defer left main based on FFR, clearly the long-term survival at 60 months is no different. What I'm trying to say is FFR is an extremely good tool for left main stenosis treatment. What is IVUS and FFR correlation today? It's no more 4. If you look at IVUS and MLA, if you look at an FFR of 0.8, clearly you can see that the area on IVUS looks like 3.23. And an FFR on the right side of less than 0.75, the area is about 2.81. So clearly the numbers for area, because of the FFR cleared data, is coming down. And recently there was an article being looked at by CGM Park where that number may come down to 2.4. This is in press at present. So clearly we are looking at a lower area nowadays in terms of FFR importance. Also, if you have MLA, which is 4, which was currently a criteria in non-left main lesions, and you divide them and see at 4 and 3, you clearly see that 68% of patients had an FFR of 0.8 or more if the MLA was less than 4. And if you came down to 3, it was still 38% had FFRs greater than 0.8. So clearly, you don't need to treat all these patients, even though their MLAs are 4 and 3. So clearly, these numbers are coming down. Your MLAs may get lower and lower in the future. What is the difference in the rate of performing PCI if you guide it by IVUS or FFR? Clearly, FFR-guided PCI reduces the number of PCI in the lab, and clearly that may lead to cost cutting and cost improvement. The IVUS versus FFR-guided PCI makes no difference in outcomes. So it's important that if you don't need to treat patients, you really don't need to touch them. The effect of downstream lesions I told you, and is very important because the effect of the lesion is dependent not only by the severity of the stenosis, but by myocardial mass. And especially in ST elevation MI, FFR cannot be used because there's a variable degree of reversible microvascular stunning, which makes maximum arterial blood flow, which is less, smaller gradients and higher FFR across any stenosis. But it can be used in the non-culprit lesion in patients with ST elevation MI. So in the end, do we need really intravascular imaging? Yes, we do. And clearly, where do you need it? Basically, in the left main, where basically you cannot see the aortic cusp of fasciculation, there's a streaming of contract, short length of vessel, and a lack of normal reference segment. Clearly, this looks pretty normal on the angiogram, but you look at the lumen area, 4 millimeter squares. Maybe today I would use an FFR and be sure whether to treat this patient or not. Most importantly, a pre-PCI IVUS tells us the characteristics of the plaque, the fibrous, calcification, thin cap fibrous atherioma, plaque rupture, and thrombi. And also tells us what is the form of remodeling. Diabetic patients have unfavorable remodeling, as we clearly know, as compared to perfect remodeling and favorable remodeling. We need a positive remodeling if we can in patients. It also helps us, for example, look at this angiogram. It shows a very, very nasty plaque in the RCA. You look at the IVUS pictures, and clearly you see a rupture plaque in this patient with possibly thrombus. It's very good for calcium, and you can see in this angiogram the calcium does not look so obvious, but you open the IVUS and you see us looking a lot of calcium in this patient. Maybe debulking would help in this patient, especially if they are very tight. In calcific lesions, the other important area for IVUS is for stent expansion. The left module shows no stent expansion, and you nicely expand them after with high pressure dilatation, your stent gets better implanted. The role of IVUS is also to know the distal difference, the proximal reference, the site of minimal luminal area, and most importantly, the length of the lesion. Clearly, a length of the lesion is important because you don't get a geographical miss, which affects. IVUS at immediate post-stenting tells us on the left side panel that the stent is not apposed well. In the middle, that the stent is adequately expanded or not. It's not really adequately expanded. And on the right side panel, it shows clearly that there is a residual plaque. So stent appositions post-stenting is very important so that malopose stents don't happen. And this is a clear example. You put a 3.5 millimeter cipher post-stented. The minimal stent area is only 3.7. You want a 5.5 area in these patients if you like to get a good long-term results, at least 5. An additional high-pressure balloon, and you bring that minimal stent area up to 6.5. What is more important for us to understand that a cipher stent at 3.5 did not get a mean stent area of 3 millimeters despite high-pressure dilatation. So clearly, it's important. So in the era of bare metal stents and the drug-eluting stents, the minimum stent area is 6.5 with a bare metal and 5 millimeter with a cipher stent or a drug-eluting stent. Importantly, if you miss the coronary artery, you get a geographical miss, your event rates are higher. All minor dissections need not be treated, and many of them close off. Intramural hematomas can be diagnosed, and these need to be fixed. Clearly, there's a large intramural hematoma in a patient which needs urgent attention and fixing with an angioplasty. IVUS-guided versus angiographic definitely reduces stent thrombosis in DES-treated patients. So IVUS-treated patients had less stent thrombosis than non-IVUS-treated patients. And in a meta-analysis of BMS trials, the 6-month restenosis was better with IVUS-guided therapy. Clearly, it also is important in 4,000 patients with DES study that the MACE events were lower in patients who had IVUS guidance as compared to angiographic, so there's survival benefit. So clearly, this shows clearly also that IVUS is important for under-expansion and for neointramural hyperplasia as to the cause of restenosis. And today, if I'd like to, important issue to look at is late stent malapposition, especially in the BVS era. So when do I use FFR? I use FFR in all intermediate lesions in stable patients where there is no definite matching ischemia in a non-invasive study. All side branch osteo post main branch stenting when percentage stenosis is more than 70. Questionable non-culprit lesions in STEMI patients. A multivessel disease to triage versus CABG versus PCI. And in PCI, multiple lesions in the same vessel. I would not use it in left main with associated lesions and culprit lesion of MI. And when do I use IVUS? When I plan my PCA, especially when I suspect calcium, when angio is unclear to anatomic features, intermediate left main lesions, stent thrombosis, and in-stent. To conclude, IVUS shows you the vessel, FFR measures the flow. Both tools help specificity and critical helpful information and should be used appropriately to optimize the outcomes. Thank you very much for your patient hearing.
I really think that was a superb lecture, huge amount of information in a very short period of time, and many, many questions which we don't have time to ask. But one thing I would just caution people, and I agree with essentially everything that you said. I think the two techniques are complementary and can be used either together or preferentially depending upon the clinical circumstance. But we tend to worship the most recent, hot, exciting new tool. and I do get a little frustrated when people treat FFR as if it is the only reason to either treat or not treat. I think we still need to use good clinical judgment. The cutoffs of 0.75, 0.8 are not arbitrary, but they're mathematical. And in a given patient, you can have a patient with an LAD lesion, which may be 70%, an FFR of 0.8, a non-invasive study showing anterior ischemia, severe angina. Well, I think you probably should treat that patient, even with an FFR of 0.8. So, and the bolus versus the infusion, it was a revelation for us. We used to use bolus all the time. We never knew if we had maximal vasodilation with the bolus technique. And there were many, I think, inappropriate FFRs that were done that underestimated the lesion severity by using the bolus technique, so I would be cautious with that as well. With respect to side branches, I agree, but many people have difficulty wiring side branches through stents to use the FFR, so to do that routinely, some people have trouble trying to do that for technical reasons. So everything you say is correct, but I would just put the caveat that you need to use good judgment and, again, in each case, make the best decisions.
There is one comment. What we have learned from this lecture, the FFR should be used for a decision making, what Sir has debated. And IVUS is important for optimization of the stenting.
Well, even more though, I think not just optimization. If I put an IVUS catheter in, I think it's useless to just put it in at the end of the procedure. If I'm going to spend the money on an IVUS catheter, I want to look at lesion length, I want to look at plaque morphology, I want to look at vessel size to make the best decision about what stent to put in and then to optimize the implantation after I've treated. So I think too many people just put it in at the end to see if it's optimal. I think you use it for its best advantage both pre and post.
I think both these procedures are totally complementary, and we could use them with our best clinical judgment to better the patient outcomes. Thank you very much.
Yeah, that was great. Great lecture.